As you've been hearing in the news, the family of Trevor Dubois is trying to make sense of why he died during an altercation with security at Royal University Hospital on Friday. Details are still emerging about what exactly happened that morning. But it was no doubt a very stressful and distressing situation for everyone involved, including frontline workers, patients, and hospital staff. And while this incident is unique, violence at hospitals is unfortunately not unique. I'm Nicole Huck, and today on Blue Sky, we're talking to emergency room nurses and doctors in Saskatchewan and around the province. Whether it's overcrowding or whether it's chaos, we're going to hear about what it's like working in these environments these days. We'll hear about efforts to prevent overcrowding in emergency rooms, and we want to hear from you. Have you had a recent experience at an emergency room or urgent care center in this province? Call 1-800-716-2221, or you can email bluesky@cbc.ca. Bryce Boynton is the president of the Saskatchewan Union of Nurses. He's in Regina studio with me. Bryce, welcome to Blue Sky.
Thank you for having me.
So what are you hearing from members right now?
Yeah, well, we hear from members, every day, multiple times a day, reaching out about the state of healthcare, specifically the state of emergency rooms, and how it's just an unsustainable system that is, leaving us burnt out and tired and regretting this potential career decision, to stay. And so, we just did a quick poll of our members, and over 60% are thinking about leaving the province or profession altogether, and it's because of this burnout.
Do you think that they're going to find better conditions in other provinces? It sounds like it's a pretty bad situation across the country.
It's hard to say, but I think it's worth putting in the effort to try to keep them here as much as we can, though.
And is this new? I mean, I don't think people have loved going to emergency rooms for a long time now. Is what you're seeing now, is it different than, say, 5 years ago?
I'd say it's different in that it's it's continued to get worse and worse and worse, and we're not seeing a lot of action.
What does worse and worse and worse mean?
We're seeing a higher population in Saskatchewan with more complex needs, an aging population that have multiple comorbidities, and ultimately, they're ending up in the ER where they shouldn't be. Emergencies should be the last resort, the last place you go when there is an issue, when it's a true emergency, when you are at risk of life and death. Instead, we're seeing people that should be seen by, in primary care with our everyone should have access to a nurse practitioner or family physician, and that just isn't happening. We also see people that are in hospitals waiting to transfer to new services that are preventing people from moving to the emergency room to an admitted bed. We have people that should be, they can't go home because they're not well on their own, but they should be looking at long-term care or are waiting access to home care services to support them in their home. And so that's holding people up in beds that shouldn't be there. They're at higher risk when they're there. That's frustrating to them, the patients, their families. It's frustrating to the nurses who are trying to move patients around to where they're best needed and can get the best services they need. It's frustrating to the ERs who are now having to line the hallways with people because we can't have a proper system flow.
What's it like day to day for nurses in these departments right now?
It's an ongoing stress of, wondering what is work like going to be today? How difficult is it going to be? What am I going to have to come across? Am I at risk of, experiencing violence today? Am I going to make it home within days? Is it going to be a 24-hour shift or a 12-hour shift? 24-hour
shift.
Yes, that happens quite often. We hear from members all the time, and
I can't imagine making a decision, without sleep for 24 hours. I get emotional if I don't get 8 hours.
I hear you. I'm the same way, and there is a lot of evidence out there that supports that you are more likely to make the wrong decision, make errors after 12 and a half hours, and so we should be looking at legislation to limit that, just like we do with airline pilots. Truck drivers.
Is there
we all
movement
have limitations
towards that?
There's been discussion, but nothing to really carry through with government here.
Why is that? Is it because healthcare workers are considered superheroes?
Well, I think we're working professionals who are here to do a job. The hero discussion, sometimes that, it misleads or directs people away from the real conversations we should be having, which are, why are we being put in this position to have to act as heroes instead of having a system and resources that support us and providing that good quality care?
Well, I want to hear from nurses themselves, other ones. Sarah Peters and Drayson McGilvery know what it's like to work in emergency departments. Sarah Peters is the clinical coordinator at Royal University Hospital in Saskatoon. Drayson McGilvery is the RN working in the emergency department at RUH. Both join me now. Sarah and Drayson, welcome to Blue Sky.
Thanks for having us.
How are you guys doing today? There's a lot. There's a
I
lot
know,
going
you know,
on. We're hearing the news, and I don't know how it's affecting people who work at the hospital.
I mean, what happened is a tragedy, and I think that it just really highlights the need for violence recognition in the workplace. Staff and patients are being put at risk, so it really needs to be focused on as a major issue going on.
Jason, what about you?
Yeah, I agree with what Sarah's saying. And then as far as what Bryce was saying about our emergency departments, treating people like heroes, and we can be when we need to be, but it's not sustainable, I would say, with how overcapacity things have gotten. And that's kind of where I'm at with that. But I agree with Sarah that was a tragedy.
Jason, what is it like going to work each day?
It's very interesting. Am I going to be doing emergency nursing? Am I going to be doing medicine nursing with all the admitted medicine patients or all the admitted ortho patients? Am I going to be doing, well, I'm always going to be doing hallway nursing, but am I going to be doing fully hallway nursing? Am I going to be opening a new hallway pod?
What does that mean? Can you describe that to our listeners when you say, am I going to be doing hallway nursing? What does that look like?
So it's exactly what it sounds like. It's patients on stretchers in hallways in the ground floor of RUH, and it just keeps expanding. It means they're in front of the nursing stations. It means they're in the alcove and nooks and crannies and closets in our trauma bays. It means they're exposed to hundreds of people walking by them every day. It means they don't have proper safety equipment. It means we're changing their oxygen tanks every 3-4 hours just to make sure they don't run out. It means no privacy, no dignity for personal care. It means we have to transport them really far away just to clean them up. That's kind of a look at what that looks like. And for nursing, it's increased workload, and it's also increased stress, and it's very disheartening because everyone's upset to be in a hallway, and it kind of comes back to us.
Have you had people pretty mad at you because they've been in a hallway and they're feeling like they don't have privacy and they've been waiting a long time? And
every day, I have the same conversation every day.
How do you deal with that and not take it personally, I guess?
I've just kind of come to accept that it's a system issue, and I explain that to patients and family as well. It's nothing to do with what our charge nurses are doing or what the nurses at the bedside are doing. We have to accommodate as an emergency department because emergencies keep coming in. It's just that bottlenecking, trying to get patients up to the ward or back home as admitted patients that make it really difficult.
Sarah, what do you think is contributing to the, I mean, Bryce talked a little bit about it, but what do you see contributing to the current strain on emergency rooms right now?
Well, it's definitely a multifactorial situation, as Bryce alluded to. You know, many people in Saskatchewan don't have access to a regular family doctor or nurse practitioner. So inevitably, the public's health problems go untreated, until they become emergencies. And then they have to present to the emergency room because they're sicker. When rural Saskatchewan people or services close, these patients don't disappear. The rural Saskatchewanites still need health care. So they just have to travel further, and they arrive in my emergency department way sicker. So then they end up being in hospital for longer periods of time.
How often do you see that, people coming from places that they would have been treated at a local hospital, but maybe it's on bypass and they're coming to see you in Saskatoon?
In the recent years, it's become on the daily. We will see service disruptions and an influx of patients arriving from surrounding communities seeking care that they could have otherwise received at their home hospital.
Bryce, you're nodding along.
Yeah, I hear about it on a daily occurrence from our members who are experiencing it, and it's not even necessarily that it is closed. It's become unreliable. It might be closed, it might not be closed, but they don't want to take the risk. They want to be seen for a true emergency, so they head into the city. where they know it will be open because we never close in the city, and so it falls on a group that it was only meant to handle so much, and it just starts bottlenecking in. Like Sarah said, it's coming in from everywhere around the province. We have people from up north flying to PA to be seen there. We have people from all of rural Saskatchewan making their way to Regina or Saskatoon because they don't know if the services they deserve in their town are going to be there. And so they've kind of, rightfully given up on that and are coming in to see, these lovely folks here.
I wonder about urgent care. I don't know how much knowledge you have about the situation with urgent care, but I know that, was it last week? There was a couple of days where Regina's urgent care was closed in the evening because there was no physicians available. How do you see urgent care working with emergency rooms? Because ideally, it's supposed to take the load off, right?
Yeah, and in theory, it's great. You're having an opportunity to be seen elsewhere in a walk-in setting where you're maybe in a less emergent need of emergency care. But unfortunately, we're not really responding to the issues that are keeping us from utilizing that service to its full potential, which is the lack of staff available, whether it's physicians or nurses. We don't have enough healthcare staff in this province to deliver the services we want to deliver. And so you either have to do one of two things. With the current way, we are trying to deliver 100% of the services with 70% of the staff and making it unsustainable, burning out our colleagues who are trying to do the best they can with what they have, and ultimately getting tired and burnt out and leaving because of it. Or we can adjust with what services we can provide based on what we have available to us. And then the third option is, doing what we can to invest to make it so we can get back to that 100%.
Well, talking about just keeping people in the profession, Drayson, you're a newer nurse. How long? Okay. We'll be back to Drayson as soon as we have him connected again. But let's talk about retention a little bit because it is, again, a problem. You're competing with people across the country, not even just across the country. You're competing with people across the world. So what are you seeing that gives you hope when it comes to retention and recruitment of nurses here?
It's hard to talk about hope some days when things are so hard out there. We hear from our members how hard it is. And my hope is, though, that we have people like Drayson and Sarah who are stepping up and saying, hey, let's do better. Let's work on this together. Let's fix things and make it so it's sustainable and so that we can stay here and actually do our job. We have people all over this province who are stepping up, willing to do the work and work with government, work with, Saskatchewan Health Authority to make sure it's a place we want to stay and work at. It's just hard to have that hope all the time when it's continuing to get worse and worse and worse, and we aren't seeing the action we feel we need to see. We've outlined exactly what needs to happen. We've sent letters in the past regarding violence, regarding the state of the ER. There was a letter from these two with 450 other colleagues, and it's received minimal responses other than alluding to these potential new beds in Saskatoon, which actually aren't fully all new. There were beds that existed before. They had people in them, and there's still people in them. They were just renamed and remarketed as new. Instead of actually solving the real problem here. And it's those people that are in an alternate level of care who are waiting to be placed either in a long-term care setting or waiting to have access to home care in their home, clogging it up and preventing people who are in the ER with these two from being placed in a medicine unit where they really should be, or just a unit that's awaiting further care elsewhere.
Drayson, we're talking about even lack of hope for some people. You're too young in your career to, I feel like you can't feel like that. You wouldn't be able to do what you're doing. You're a newer nurse, 5 years in, 2 years in emergency. What does all of this do to the ability to keep people like you in the profession?
It doesn't keep us in the profession, to be quite frank.
Do you see people? Do you have colleagues, young people like yourself, who have left? Where are they going?
Absolutely. There's colleagues that are staying in nursing but leaving emergency, and we need people to stay in emergency for longevity. We need mentors. We need people to keep educating us so we can provide good care. So there's used to be this natural churn where people would leave, and that churn was 10, 15 years and try a different profession. Now it's 3 years, try a different profession within nursing still. But I know a lot of colleagues who are completely leaving the nursing profession altogether and going into private care, or just starting to something else. So it's very disheartening, and it's hard to get them to come and stay when nothing's really changing for us, and we can't really offer any hope, and we just keep adjusting as emergency nurses. We keep overcoming and adjusting these issues because we still need to serve the people of this province. So we do our best to do that by opening hallway beds and keep flexing and keep working. But it's just like every day having the same conversations about wait times and about waiting for a bed upstairs. It just like wears you down.
Drayson, you've only been in emergency for 2 years, but do you consider, when you look around the room, do you have the most experience in the room? Do you have a lot of people with experience that you can look to mentor yourself? You're talking about turnover. Just what's the actual reality of what you're seeing?
Fortunately, I do have some people like Sarah, who are great mentors, and they've been keeping the department going. But I would say back in the day, I've been told I would be considered a new grad until 5 years. Now I'm considered like intermediate staff, and I've only been in emergency for 2 years, like intermediate to senior, which I wouldn't consider myself that, but that's kind of the reality when you look around the room. And my 3 coworkers have less than a year experience combined. It's a little scary.
Sarah, what are your thoughts on that?
I will echo what Drayson's saying. As a 20-year emergency nurse, I am exhausted trying to mentor and grow strong emergency nurses. I have put just recently, I lost 2 of my very close mentees. I put a lot of work, a lot of effort to growing and training, but the conditions in the work environment were just so unsustainable that those 2 individuals left to seek, better opportunities that, gave them a work-life balance. And not that I fault them for that, but it takes a lot for me as one person to, invest that time and effort into growing them on top of doing my job, because I'm not getting extra pay or extra recognition. That's just me identifying really strong, vibrant nurses who have the potential to be great emergency nurses, and to develop those people. And just to see them leave, it makes me so frustrated, so disappointed. And then really worry about the future of emergency medicine, because people like me, with 20 years experience, I can count on one hand how many are left in the department with that kind of experience. So when you lose those people, you're not just losing people, you're losing their knowledge and their experience too, which is a far more valuable resource than just having like shoes on the ground. You know what I say? You know what I mean?
I have to say, this is very alarming to me. Like, I feel scared if I have to end up in emergency at this
Don't be
point.
scared.
Don't be scared. But I mean, why should I not be scared, Sarah? Tell me. You just told me about how overcrowded it is. You've told me about how inexperienced the staff are. Like, why should I have faith, I guess, in the medical system right now?
You should be scared that the government's not investing in healthcare and making it a real priority for change. But I tell you, the work ethic of the nurses and the staff on the front line is non-negotiable. Like, they know their mechanisms to reach out for help and know when we need to escalate concerns. So my staff is exceptional, regardless of their experience. It just takes time and effort to grow them to be, fully self-sufficient. But like I say, we have those mechanisms, and our work ethic is not questionable.
And if there are nurses listening right now and they want to join the conversation and tell us what they're seeing in their part of the province, it's first names only when you call in. You can call 1-800-716-2221, or you can email bluesky@cbc.ca. Drayson, I just want you to paint a picture of hallway medicine that you're experiencing. Take me through. Just kind of give me some examples of some of the challenges that you're experiencing with that on a daily basis.
So I will refer to there's hallway nursing within our actual emergency department, and there's hallway nursing that's like a pod adjacent to our emergency department. That's just a hallway There's no rooms. It's just a hallway with beds in it. So I'll refer to that. That's called EPOD, and there's FPOD as well. So EPOD is between the children's emergency or children's OR, the adult OR, and the emergency department. So painting a picture is those patients are seeing all these critically ill patients go by them every day. They have to go to the bathroom. If they're able to walk, they have to walk quite far, or they go and we just have to take them quite far to help clean them and change them and provide them good care. I had a patient say he counted the one day he saw like over 1,000 people walk by that day. So just the exposure alone is a lot. And then also our CT machine is in the emergency department for weekends and after hours. It's the only one available in RUH. So ICU, CCU, any floor, inpatient floor is bringing these very, very critically ill patients through a very narrow corridor because there's other patients in that hallway. So they're bringing a big ward bed, 6 pumps sometimes for ICU patients, plus the ventilator, trying to squeeze everything through. And that's a huge risk because if one of those lines gets pulled out, that could be like a couple minutes off that medication for some of those critically ill patients is difference between life and death for some of them. So it's just very unsafe in that regard. So just safe transport ways, not even just for the patients in the hallway, but for other patients, is a big concern.
Grayson, you told our producer, Joelle, that in one day you had 54 admitted patients in a department built for 28 emergency patients.
Yeah, that was sometime last week, and we dealt with it, and we were able to overcome that, obviously, but it was very hard, and we had to open more hallway beds, and it just makes no room for emergency patients. We have assessment rooms to pull patients in, see them, put them back in a waiting room, but some of those patients need to be continuously monitored, and it's very limiting in that situation. So yeah, those numbers kind of explain our capacity issues. And I think St. Paul's at that time had close to 40 or 35 admitted as well. So between our two departments, we already filled up all the space that they're planning on making in city. So it's even with city, we're still going to be over capacity.
I'm Nicole Huck, and you're listening to Blue Sky on CBC Radio 1. Today, we're checking in on the state of emergency room care in this province. We're joined by emergency room nurses. We'll soon be joined by a nurse practitioner from rural Saskatchewan and an emergency room doctor who's involved in the creation of 811. And as always, we want to hear from you. Have you recently had an experience at an emergency room or urgent care center in this province? What was that experience like? You can call 1-800-716-2221, or you can email bluesky@cbc.ca. Now, we do have some guests standing by, but I do want to bring in another person right now. So Michelle O'Keefe knows how hard it is to get an appointment with a primary care provider right now. She's a nurse practitioner and past president of the Saskatchewan Association of Nurse Practitioners. She works at the Grenfell Health Centre, and she joins us now from Grenfell. Michelle, welcome back to Blue Sky.
Thanks very much for having me.
So what are you seeing in Grenfell right now and your area?
When you're looking at the primary care shortage, when I started this position in June, it very quickly, like it was 4 to 6 months out before you could even get an appointment with me. So the job that I filled had been vacant for 5 years. And then, as soon as like a month later, patients are calling thinking, great, there's someone here now. And they have a 5-month wait to even see me because of the appointments are all already booked.
What's your patient load like now, Michelle?
Since then, it has decreased a little bit because there is a part-time physician that comes in a couple of days a week. So if you're calling to book an appointment now, it's closer to the end of February. But on average, when I was in Indian Head, I was seeing between 1,500 to 1,800 patients as my patient load. And the average load is supposed to be around 800 to 1,000 patients per nurse practitioner. So that being said, I'd been in Indian Head for 12 years. So I'd collected probably a higher population because I was the one that was there consistently. We're talking about turnover. A lot of the SIPA physicians that come in are on a 3-year contract and then they're gone. And you don't really have that continuity of care. When it comes to urgent or emergent things that come up for any of my patients, there's some time that's set aside for urgent things, but it still might be a week to a week and a half out before I can get people in. Sometimes when that sick kid comes in with a fever, we squeeze them in somewhere, but otherwise we're sending them to the ER because there's no capacity to see them here, even if it could be dealt with in a primary care setting. You're supposed to see maybe 12 to 16 patients in a day, and you've got 22 booked. So there's only so much that one person can do, and you end up sending that into the ER settings. In my area, Indian Head has 2 vacant nurse practitioner positions. Broadview has a vacant nurse practitioner position. So if you had those things full and they were able to see patients as well, that would certainly be able to decrease the workload on the emergency departments. A lot of the ER patients end up in Indian Head. There is some virtual physician coverage and some Monday to Friday 8 to 5 kind of coverage at Wolseley and Broadview, but the closest 24-hour area would be Indian Head. When I worked in Indian Head, we also would see kind of the opposite effect of people from like White City, Emerald Park area. They would travel to Indian Head for their emergency room treatment because they knew that potentially the wait might be shorter, but then that meant a facility that's meant for a rural or smaller population has, there's one day I saw that they had about 30 patients in the Indian Head ER, and there's 5 rooms there. It's not meant to be used in that capacity. So certainly that puts a strain on the entire system.
I want to play a clip here to everybody. Last week, there was a news conference, and health critic Keith Jorgensen said rural residents are being put at risk. Take a listen.
Of the 365 days in the year, Watrous Hospital was actually closed 125 times. And of the 240 days that it was actually open, we know many of those 240 days, there wasn't actually a real doctor on site. And of all of this was managed by SHA and the government in the most chaotic way that you could possibly imagine. Of these notices here, none of these were actually put on the SHA website nor on the local politician's Facebook page. And of all the alterations in services, so when the hospital was open but there was no doctor present, the government and the SHA never told any of the local people when there was an alteration service. So basically the people in Watrous had no idea when their hospital was open and had no idea what services that the hospital was able to offer when it was open. And an absolutely striking example of this absolute chaos, there was a day when Watrous Hospital was open for 25 minutes in a day. And I would ask the Minister of Health, what medical procedure can a hospital perform in 25 minutes? It's pure chaos. And the end result of this is a loss of faith of local people in their hospital. And the end result of that is even when the hospital is open and fully staffed, people stop trusting it and they stop using that hospital. And that increases the pressure on surrounding hospitals, whether that be in Saskatoon or other surrounding rural facilities. Often, I think in rural Saskatchewan, you don't live in a community that has a hospital, you live between 2. And you have to decide which direction you're driving in. And so knowing if the hospital is open and what services it has is critically important. And Watrous is like a glaring example just because of the sheer number of them is insane to be closed that many times. And when I visited Watrous, I think 4 or 5 times this year, and you talk to local people, they don't even think about going to the hospital even when it's open because they don't trust it.
So those are some strong words. That was the health critic Keith Jorgensen speaking last week, and the province started publicly reporting closures online in November. Every day at 4 p.m., the province publishes current or upcoming ER closures. And the Saskatchewan Health Authority says that virtual physician program is helping with rural closures. They have 2 new physicians expected to start in Watrous in February. I did call the mayor of Watrous on Friday just to ask him what his take was, and he said that he is happy with the progress that is being made right now with SHA. So I just wanted to add that to the conversation. But Sarah, Drayson, Bryce, all of you work in healthcare, nurses in this province. What's your reaction to what we just heard there?
Yeah, virtual, it has its purposes. I can understand that, and maybe being happy with certain progression on that. That's fine. I think, with Michelle joining us, there's a great discussion to be had. Sarah mentioned earlier, it's a multifaceted issue of why people are ending up in the ER, whether it's the rural, like Keith mentioned, or people just not having access to things like primary care. Over 300,000 people in Saskatchewan don't have access to a nurse practitioner or family physician, and that's scary because that should be your first line of defense if you're like, I don't know if something's right, or I might need to be checked on for this, or my medication might need an adjustment. No, but instead people are looking for a potential walk-in clinic if it's available, if it exists, an urgent care if it's open, or they're ending up in the ER where it's not an emergency. And I understand they're scared. They don't know where to go. You've mentioned earlier you're scared, so I can understand why they end up there. We should be making sure we do everything we can within our power to make sure they have the appropriate place to go, though.
I do want to go to the phone lines. We have Mark on the line in Saskatoon. Mark, welcome to Blue Sky.
Hey, thanks for having me.
So why did you call in today?
Well, I'm hearing people, kind of talk about, this is the problem or that's a problem. There's a lot of stuff going on in the healthcare system right now. And, one thing that was kind of, shocking to me and my wife just having a newborn infant is, when you call into the medical helpline and you're reporting some symptoms that are concerning, your infant is, they're saying, yeah, you need to get to the medical ER right away. So, we follow suit because, the temperature's in the red. It's, amongst other symptoms, we get down there, and as soon as you get to the ER in the children's hospital, they say, hey, you got a 4-hour wait here. I know they're doing their jobs and checking up on the kids, but for 4 hours, we're sitting in the waiting room with an inconsolable child. And I think the medical sort of environment is changing too. One other thing we've noticed is before, if you did have like a newborn, you were usually bumped to the front of the line. If you were in a clinic or anything like that, they kind of prioritized them, if it was something that was maybe urgent but not, something you needed to rush to the ER. But they don't even do that anymore when you take your kids in. It's for myself, if I have to lay in the hallway and I pass, whatever, but I want my kids and our kids to be, a priority in the system. And, without getting, maybe it's a unpopular opinion, but you get what you pay for. If healthcare is, free, and I'm doing air quotations with my fingers now. I've had a relative who was in the industry of selling medical gear to the healthcare system. And whenever you get something that, is government ran and operated, your costs go up exponentially. The equipment he used to sell versus, in the States versus when he came to Canada and started selling it, it's quite a different price point for what things sell for. Just medical equipment, I don't think it's worth that. And he said it sure as hell wasn't worth that. But, there's a lot of changing going on. And
Mark, if he sold that to a private company, would it be cheaper?
Oh, absolutely. I think whenever you have, no matter what department it is of government stick their nose into something, usually your efficiency goes down, your costs go up. I've seen it in a few different industries, which I'm not at liberty to elaborate. But I definitely think that, there's a lot of overspending. I think, there just needs to be a little bit more transparency and accountability of where money goes. I think, and maybe I'm unprepared for this conversation. I probably should have gathered all my statistics, but, I'm just a normal working person. But, getting back to my main point is just with kids and stuff, a 4-hour wait time in the ER when you have your infant in critical condition. I know they're doing everything they could, but, one other little thing I thought was interesting. Sorry, go ahead.
Well, you called 811 before you went in?
100%. And, we're very, we're reasonable people. We wanted to make sure this wasn't a waste of their time and stuff. And we did all the tests and they said we did the right thing when we came there. Said, yeah, we definitely need to see your child. But, I think there maybe is a little bit of slipping too. That's maybe going on. Like when we went to the, just to have our child and give birth to them. like it was a nightmare in the hospital. Everything went wrong. The food we got served, I got food poisoned off of it, which, they said you can call in, but I don't think it would have. I don't know. Maybe I should have. Maybe that's on me. But even my wife at the time had an epidural, which ran out. The nurse.
Well, Mark, sounds like you've had some pretty negative experiences. There's some other people I want to bring into this conversation, but I do appreciate. Sure. I want to put some of the things that you brought up to them. So I do appreciate you calling in today.
Yeah, it's more of a rant. Apologies.
No, that's okay. We take it all here. So thanks, Mark. That was Mark in Saskatoon. I want to bring in another guest because he was talking about an infant with a fever. I mean, I'm a parent. I've been on that phone with 811 before, and you're trying to figure out, do I have to risk going to emergency at midnight with a sick kid and all the stuff that you're going to have to deal with when you're there, or is it something that can wait? And somebody who knows a lot about that is my next guest. So Dr. Puneet Kapoor is the creator of the Physician Referral Program for Saskatchewan's 811 Healthline. He's also an emergency physician in Saskatoon and assistant professor at the University of Saskatchewan. Dr. Kapoor, welcome to Blue Sky.
Hey, Nicole, thanks for having me.
So you were listening to Mark there. What were you thinking when you heard him? And you probably talk to people like Mark all the time.
Yeah, absolutely. So certainly appreciate Mark's frustrations with the care that was being provided to his family. My role in, I guess, the very, very large healthcare system is fairly narrow, and that's mostly as the medical director of 811, and I lead the virtual physician programs there. So I can happily speak to the 811 program. And I think Mark probably actually said it best. One of the first things lots of people do is call 811 because they're like, hey, I'm, as Mark described himself, a layperson. I want to just ascertain whether or not this is an emergency and if this is something that could be treated at home or something that requires urgent referral to an emergency department. And 811 does that job really, really well. 811, for those who may not be familiar with it, is mostly nursing-led, some physician backup. It's been operating effectively for 20 plus years now. I think last year was our 20th anniversary. And it's an excellent first choice for the concerns just as Mark's raised them. If you're sitting at home and wanting to figure out if this is something that can wait a day or if this is something that needs to be figured out right now, I would unanimously recommend that as a first choice resource for the people of Saskatchewan.
Dr. Kapoor, what are the most common reasons why people call 811?
So 811, maybe I'll preface my answer with giving you just a quick overview of what 811 provides. So 811's got a bunch of different service lines. So we provide care for primary care support. People worry they've got a cough, cold, fever, maybe a community-acquired pneumonia. 811, buried within it, actually has a number of other service lines. We actually take care of emergency departments throughout the province. We have separate resources for mental health. We have separate resources for postpartum individuals or people who are suffering from postpartum depression. And then we actually have separate support lines for long-term healthcare management. So I think your earlier guest, Mark, his comments were about the primary care. And primary care means anything. Pretty much you can call in with anything under the sun. So whether it be chest pain, abdominal pain, cough, fever, we're well positioned to deal with anything under the sun. What happens is, actually, just to quickly walk you through the process, folks call in, they speak with one of our registered nurses, and the registered nurses try their very best to see if they can sort the problem out over the phone. Some of those problems obviously can't be solved out over the phone. They say, listen, this sounds like a legitimate emergency. Maybe you've got crushing chest pain. You need to go urgently to the emergency department. As you can imagine, we can't do CPR virtually. And other concerns might be something that more mundane or more simple that we can deal with remotely. You've rolled your ankle, stubbed your toe, you've got a bug bite. And for concerns that fall in that middle area where it's obviously not high acuity, but not obviously something that can be easily taken care of at home, for those reasons, we have physicians who are available on Healthline 811. And if you fall in that sort of that middle zone, you get connected to one of the virtual physicians who tries to come up with a diagnosis and a treatment plan.
How many physicians?
On the primary care side of it, currently have about 25 physicians. They work in shifts of 8 hours duration, and we cover from 8 a.m. to midnight every single day. And that was something that was brought about during the pandemic. It was an initiative that was launched when so much of healthcare was closed and folks could not get in to see their doctors. I was the very first one. I was the very first virtual physician on that program. And since that program, we've successfully seen, I think our last numbers were over 60,000 people for the duration of the program. Wow. And of those 60,000, 75% consistently year over year have avoided an unnecessary emergency department visit.
75% of people that you call you don't send to emergency? Or am I getting that wrong?
Absolutely.
Okay.
Yeah, so if you call in, let's say 100 people call in, some will immediately be sent to the emergency department, so that's sort of already out of the equation. Some, the nurses will be able to provide sensible discharge instructions so they don't get connected to a physician. Then that middle strata comes through to the docs. Of that middle group represents about 60,000 people. Healthline overall has probably seen north of 250,000 people in that time. But that middle group comes through to the physician group. And of that 60,000, about 75% don't need to go onward to the emergency department.
So you're also an emergency room doctor. How often do you see people show up in emergency that you think really shouldn't be there?
You know, this is, Nicole, a contentious topic in emergency medicine.
Let's dig into it.
Yeah, absolutely. So I've certainly, as medical director of Healthline 811, my physician colleagues will often send me a note saying, you know, Puneet, I don't feel this person was appropriately sent to the emergency department. And I'm sympathetic to that, but I would remind them of two important facts. The goal of Healthline 811 is to be as safe as possible, right? We're dealing with people entirely virtually. We can't lay hands on them. We can't lay eyes on them. We can't examine their lungs. We can't listen to their heart. So part of safety means being cautious, and we are necessarily more cautious than most because we're operating entirely in a virtual care environment. That allows us to give sensible advice, and if they come to the emergency department and felt, hey, you know, this is an emergency, that's okay. That doesn't represent a miss or a failure of the system. That's intrinsic to the caution that allows us to build a culture of safety. The second thing, and speaking as a emergency doc, people are like, well, why do you come to the emergency department? You have to look at it from the patient perspective. Between 5 o'clock and 8 a.m., if you feel unwell for whatever reason and you want to see a doctor, there's essentially nowhere else in society you can go. So I'm sympathetic from both ends of the equation.
I'm curious. We do have a couple of emergency room nurses on the call right now.
Sure.
I'm curious, both from Sarah and Drayson, how your jobs interact with people who have interacted with 811 before they came. How often are you seeing people who are there because 811 told them to come?
Well, can I speak to that, guys?
Yeah, you go for it, sir.
So, I mean, Puneet already alluded to it, right? We're only going to see that middle strata of patients, right? So we don't see all of the calls that come into 811. But inevitably, we see 100% of the patients that present to emergency, and their line to start off with is, I spoke to 811 and they told me to come in. So, you know, we have a very narrow point of view when it comes to that, because we don't know all the patients that are, you know, cared for out virtually outside of the emergency room. So I don't know if that's necessarily a fair question, because every patient who presents to emergency who spoke to 811 comes to emergency.
Yeah, true. I'm just wondering. We're coming up closer to the end of the show. 811 is great for people who have definitely a medical problem. That's why they're there. But we do know from even talking to different groups who are working with people in the homeless population that people are sometimes brought to emergency because people don't know where else to take them. How often is that the case, especially in maybe some of the bigger cities? And Bryce, you're nodding feverishly, so go ahead.
Yeah, well, it's always great hearing from the experts who are doing the work. So yeah, I nod lots. I'm like, yeah, I hear you. I agree. Well, I think we heard it. I think it was described really well there with 811. You know, when people have options, they can avoid going to the ER for something that isn't required, isn't technically an emergency. You know, when people have access to a nurse practitioner or family physician, they can avoid the ER. When people have access to urgent care for something that might be, you know, a bit that's less than emergency, but a bit more than waiting, you know, a month or whatever it is, it might be to get into their family nurse practitioner physician. they avoid it by going to the urgent care. When people have access to care within their home through home care, they can prevent going to the ER for something that could be managed within the home. And so, we have all these things that we've talked about as great examples of ways to keep people from going to the ER if they don't need to be there, which could allow them to do the emergency medicine that they signed up for. And so I can understand, though, when people are scared. Mark outlined it well. He's worried for his kid, and I get it. I feel for him 100%. That is the place he would go. He's worried about his kid. He wants to be seen. Whether it's him and his child, whether it's someone and their grandma, they're just wanting to do the best for their loved ones, and I totally appreciate it. And so we need to make sure that they have access to the services they need. And that means making sure we have access across the variety of types of services we provide.
There's a couple things you just brought up that, we have Dr. Kapoor on the line. I want to go to him. But Dr. Kapoor, there's two things here. One, we were just talking about the access to family doctors. Do you see 811 kind of being able to pick up the slack a little bit for people who don't have access to their own family doctors? Like, how many of the people that call 811 don't have their own family doctors?
Yeah, so let me answer your question in two parts, I guess. So how many do not have family doctors? I don't have an exact number for you, but given my experience, if I was to estimate, I would say a very high proportion of them don't have family doctors. So as your other guest noted, if you don't have any other options to care, and one of the first things that comes to mind is calling 811, and we're happy to hear for those people. When we designed the program, our goal was to supplement but not replace. We're not here to replace your family doctor. We wanted to build a system that would work synergistically with your family doctors, and the way we do that is all the care provided by 811 is included in your provincial health record. So when you see one of the 811 docs, all of the, whatever we talk about, whatever we diagnose, and whatever we treat you with, all of that gets pushed up to your provincial EHR, and everyone can look at their own record right now. So then if you do follow up with your family doctor in Weyburn or wherever in Estevan, the entire record of care and the clinical decisions that are made are available throughout the entire province. Happy to see anyone for any reason, but we aim to be part of the continuum of care, not to replace, but be an adjunct to those who may already have family doctors.
And my last question for you, Dr. Kapoor, before we let you go, is just location. Bryce here is a nurse in Larange. I know that you're seeing a lot of patients who are coming from places where emergency rooms are very far away. What do you see the role in helping communities that are very far away from an emergency room with 811?
So we actually keep open emergency departments throughout Saskatchewan. One of the roles inside 811 is we actually hold open, for example, Porcupine Plain or small emergency departments throughout the province that don't have a physician available. Those folks who present to those emergency departments actually see another group of physicians inside 811 who actually provide virtual emergency services. So 811 as an umbrella organization has within it these different lines of business. So we actually try to keep emergency departments open all over Saskatchewan. And currently that program, the Virtual Physician for ER program as it's known, supports 30 rural emergency departments and tries to keep those emergency departments open for exactly the reasons you've outlined. In the absence of that, say you're not near any emergency department, be it small or big, then we happily take calls from all over Saskatchewan. I personally have taken calls from the U.S. border all the way to NWT, folks who simply have no way or transport. It's frozen. They've got to be extracted by plane. They've got to get over a frozen lake. And as best as we can, we try to offer treatment options for anyone, anywhere in Saskatchewan, essentially at any time.
Well, Dr. Kapoor, we're out of time, so I just want to thank you so much for making time. I know that you're on rounds today, so I appreciate making time for us today.
Thanks for having me, Nicole.
You're welcome. That's Dr. Puneet Kapoor. He's the creator of the Physician Referral Program for Saskatchewan's 811. I want to thank all of the guests who have been part of this program today. We were joined by Bryce Boynton. He's the president of the Saskatchewan Union of Nurses. Thank you.
Thanks for having me.
Sarah Peters, clinical coordinator at Royal University Hospital in Saskatoon.
Thank you.
Drayson McGilvery. He's the RN working in emergency department at Royal University Hospital.
Thank you.
And Michelle O'Keefe, a nurse practitioner and past president of the Saskatchewan Association of Nurse Practitioners. It was a good one today. If anybody else has thoughts on what you've heard, you can email bluesky@cbc.ca.